Hello, I'm Dr. Anil Gudi, consultant in reproductive medicine and surgery. And today I'm going to talk to you about the role of intrauterine insemination in unexplained infertility. This was a very good study which looked at intrauterine insemination with ovarian stimulation versus expectant management in unexplained infertility, a randomized controlled two-center trial. And what it did, it looked at the effectiveness of 3 cycles of stimulated IUI with clomiphene and letrozole, remember that, versus 3 cycles of expectant management, which means that you waited and tried for a pregnancy for unexplained infertility. Two-centered RCT, women less than 42 years of age, BMI less than 35, unexplained infertility, bilateral patent fallopian tubes, and a normal sperm count, a progressive motility of more than 32%, and a count of more than 15 million. What were the protocols used? Clomiphene citrate, 50 milligram to 150 milligram, days 2 to day 6, letrozole, 2.5 milligram to a maximum of 7.5 milligram. Estrogen and LH were measured, and this is slightly different what they've done in their setup. So they waited for the estrogen levels to go up, and if it went up below 400 picomolar liter, the first ultrasound scan was planned. LH tracking was done once the follicle reached 14 millimeter and not 16 millimeter. IUI was done 24 hours after the LH surge or 36 hours after HCG. In the second and third cycle, a scan was not required unless the estrogen levels were more than 2000 picomolar liter, and what they were looking at is if they had multiple follicular growth. The semen sample density gradient was 45% and 90%, and a 0.5 ml of insemination was done. Luteal phase support was not given unless serum progesterone levels were less than 20 picomole a liter. Again, what it means is that if you see there is a problem in the luteal phase, 7 days after insemination, then you add progesterone. Again, the belief is that that may improve the chances of implantation. Again, if you have a look at looking at IVF or looking at frozen embryo replacement, the role of progesterone on the day of embryo transfer or the day of implantation seems to be important. And it is very important that we think about these. If more than 3 follicles, in those cases, uterogestane was given. If more than 3 follicles were seen, IUI was cancelled. What did the results show? The results demonstrated that IUI group had a much higher live birth rate compared to expectant management. The birth weights were similar. The 31% live birth rate was there in the IUI group, 9% in the expectant management group. The miscarriage rate was around 16% in the IUI group and 9% in the expectant management group. Time to pregnancy was certainly faster in the IUI group. So in conclusion, we would say that 3 cycles of IUI with ovarian stimulation, either with clomiphene or letrozole or with gonadotropins, is better than just waiting. For couples with unexplained fertility, we should think of this IUI with stimulation, not natural, as a first line of therapy. What we know is, if you have read the study which my hospital did, that when you compared it with IVF, not just with natural conception, when you compared it with IVF, we had a 26% live birth rate through IUI, which was comparable to 1 cycle of IVF. Thus, before you rush in and start offering IVF, I would say give unexplained fertility 3 trials of IVF. The other most important factor which we should be looking at is the amount of sperm that we inseminate. And it should be more than 4 to 5 million. If you can get the wash sample more than 4 million sperm, motile sperm, pregnancy rates are certainly significantly better. Thank you very much, Anil Gudi. Hello, I'm Dr. Anil Gudi. I am a consultant in reproductive medicine, surgery and assisted conception. As you all know, that Fertility Courses is a free online Facebook page which aims to give knowledge by discussing cases, by discussing reviewing articles, and by trying to spread as much knowledge as possible. I do see a lot of queries coming in, and I would request you that if you wish to get your queries answered, if you could drop an email on fertilitycourses@gmail.com with a detailed history. I'll be more than happy with my team to answer it on a Thursday when I'm in the hospital doing a review session of our cases. If you want any review cases discussed or articles discussed, I'll be more than happy to see it. I would be extremely grateful if you could rate this page and share it, because knowledge at the end should be shared with as many people as possible. This will improve the quality of medicine we provide to our patients. Thank you, and I hope you continue to enjoy the teaching on fertility courses.